Hello and welcome. This is now finally the second video in my two-video series on the curious case of ivermectin in Brazil. In this case, I'm going to be dealing with the science, just the science, not the process. If you want to focus on the process or learn about the process of publication of this paper, you can follow my other video, which is linked up there. But in the meantime, let's focus on the science and get started. One viewer asked me recently if I would mind doing perhaps a little intro summary of a video before going into all the details, because I tend to wander. So let's do that this time. I'm going to do that. It's going to be my little chapter 0, our TLDR, and you can decide yourself if you want to follow along for the rest of this. There will be chapter markers in the description below. So what is it that this study claims? This study claims it's an observational study, a retrospective observational study in the city of Itajai in Brazil. It claims that prophylactic use of ivermectin is associated with a large drop in infection rates. Further, it claims that prophylactic use of ivermectin is associated with much lower hospitalization and much lower mortality. In this case, they use something called propensity score matching. My summary is that all of this is really weak tea, and I will describe some of the weaknesses in the paper. The weaknesses are many, so I won't describe all of them, but I'll describe some of them. The study is very weak, and it's probably almost certainly confounded by multiple variables that they never tracked or never even tried to track. It's also the case that we simply don't know whether the people in the treatment group, who were presumably the ivermectin users, actually took ivermectin, or if any of the participants, including the non-ivermectin users, took ivermectin, either before or during the study. In fact, it's quite likely that the participants, most of the participants, didn't actually take ivermectin during the study, and we have data on that from the city of Itajai itself. Also, the most important controls are all missing. There are a number of controls that they do account for, but those are not really the most important controls for this particular type of observational study. Finally, the analysis is really weak. The data is a mess. It's just a mess. The protocol, the analysis protocol, was modified after the analysis was completed, and then it was redone. This is a big red flag. And the issues just go on and on. I will not be able to cover the issues all of the issues in this short video. Okay, let's get into the details of this study. What are the claims that it makes, and how is it set up? This is the basic study, the title page, as I discussed in the previous video. And so this is a prophylaxis study. It's an observational study, and it was based on a registry or a citywide program that was done from July through December of 2020. It was done in the city of Itajai, which is in southern Brazil. So here's the state of Santa Catarina in southern Brazil. This is now a blow-up of that state, and the city of Itajai, or the municipality of Itajai, is highlighted in red. The basic study layout is as follows. The city itself offered everyone prophylactic ivermectin. They offered it at a dosage of 0.2 milligrams per kilogram per day, and it was supposed to be taken for 2 consecutive days, once every 15 days. Those who accepted the offer and took a prescription for ivermectin, they were required to report illness. In addition, this data was then used for this retrospective observational study. So the program ran, as far as the study was concerned, from July 7th, 2020 through December 2nd, 2020. So under 5 months, just a little under 5 months. The research questions raised by the study are relatively straightforward. Did ivermectin users differ from ivermectin non-users in terms of getting infection, because this was done prophylactically? And the second is, even though it was done prophylactically, did ivermectin users differ from non-users in hospitalizations, and death when they got infected. For the second part, they used a method called Propensity Score Matching, which I'll discuss a bit later. This is from the paper itself, and I've highlighted a couple of things. As I mentioned, they ran this from July through December, beginning of December in Itajai. They describe it as prospective, but notice here they say study design, institutional review board approval, and analysis occurred after completion of the program. So in no way was it prospective. Now here the program is inviting the entire population to a medical visit to enroll and to compile this baseline medical history information and so on. And then if there weren't any contraindications, ivermectin was offered as an optional treatment to be taken for 2 consecutive days every 15 days at this low dose. In cases where a participating citizen became ill, they were recommended not to use ivermectin or any other medication in early outpatient treatment. So that is, this was used as a prophylactic, but not as an early treatment. And then the outcomes of infection, hospitalization, and death were automatically reported and entered into the registry. Now, that's the program. Then study analysis consists of comparing those ivermectin users with non-users. So we haven't defined the users yet. This is the flowchart for the prophylaxis part. So they started here. Now, how do they define ivermectin users? This was basically the people who took up the prescription, then above 18 years of age, and then they had those who were COVID-19 free until the beginning of the program. For all users, they basically had everybody in Itajai without COVID up till then who was above 18. And then they just excluded the first group, and that became the non-users. So that's the basic idea. The users were the people who signed up for the program and were over 18 and not contraindicated. The non-users was everybody else in the city of Itajai who was over 18. So from this, most people took up the offer. So from this, 113,845 were in the ivermectin user group, and 45,716 were in the non-users. Then they look at cases, and they see that cases are higher in the non-ivermectin users. And so that means, in their interpretation, that ivermectin use was associated with a 44% reduction in COVID-19 infection rate. However, this has a lot of problems, as we'll see. So what are the groups? The groups that they are comparing are what they call ivermectin regular users and ivermectin non-users. And what makes a regular ivermectin user in this case? Well, in this study, what they did is they said those who were given prescriptions for ivermectin prophylaxis. That is to say, they picked up that first prescription, and they're supposed to come back and pick up the prescriptions periodically. They don't actually track how much ivermectin was used, although they do log how much ivermectin was picked up, and they had to pick it up multiple times. There are a bunch of obvious problems in this. One is that the people who took up this offer are self-selected. So are they comparable to the ivermectin non-users? Were they people who were paying attention to the news, more aware, able to drive, able to get to the sites on the days and availability when they were there? There are lots of ways in which those populations and that self-selection might pose a problem. In fact, it would be hard to imagine that it would not pose some form of confounding factor. A second one is, were these people, either the ivermectin users or the non-users in the eventual groups, had any of them been taking ivermectin prior to the onset of the study? Given the visibility of ivermectin in Brazil around this time, it's quite possible, in fact, quite likely, that some of them were taking ivermectin previously or taking it on their own during the trial, during the program. Excuse me, it wasn't a trial, during the program, and we have no idea about that. And third, did the people who were the regular ivermectin users actually take ivermectin regularly? We don't know. That was not tracked. So let's start with the first. Are they comparable cohorts? So the variables that the authors analyzed, and they used these for propensity score matching, they include age, sex, and a variety of comorbidities in previous disease and smoking. Then they say these were adjusted as confounding factors and used as variables for batching and matching groups for propensity score matching. This sounds like kind of the right angle for propensity score matching. However, notice what's not included here. There are no adjustments, and there's no tracking or awareness or attempt to track anything that's related to risk. So while they did control some comorbidities in propensity score matching, none of those are risk variables. None of those have anything to do with the risk of contracting COVID. Even though this was a prophylaxis program and ostensibly a prophylaxis study. So they didn't account for occupation, they didn't account for living environment like household density, neighborhood density, other socioeconomic factors. And we know that those play an enormous role in the likelihood of somebody contracting COVID and also the outcome after they do contract COVID. None of those were looked at. So why should we look at these? Well, worldwide, COVID has had a huge impact on the poor. Absolutely huge impact on the poor. In any place, the poor have had worse outcomes, higher rates of death, just much worse than those better off. And those who took up this program, so those who wound up in the eventual ivermectin user group, they made an investment of their free time. They made an investment of their time, and they made a commitment to come back and pick up ivermectin in future weeks. So they had time and plans and awareness, all of which suggests that the socioeconomic factors and contributors to whether somebody entered this program at all might be considerable. In fact, they might be overwhelming. Importantly, those risk factors, the risk factors for infection, like living in a crowded environment, poverty, poor access to health care, having a job where you can't work from home, those are also risk factors for poor outcome, for poor prognosis. So even though this was a prophylactic study, those risk factors could contribute to outcome in terms of hospitalization and death. There are a bunch of other missing considerations. This is one that popped out at me on the discussion site at Cureus, the journal. So the journal does a nice thing, which is they allow discussion on individual papers. And from this discussion, Eddie Nuret points out he was concerned that the data wasn't being made available, which is true, but also pointed out that over the time of the program itself, that is between July and beginning of December 2020, there were a lot of changes in Itajai in terms of non-pharmaceutical interventions, or what Nuret refers to as sanitary restrictions. So basically, things like social distancing, masks, restrictions on shopping, restaurant capacity, all of those types of things prior to vaccination were being put in place during the same time as this program was being done. And they're going to affect the rates of pre-vaccination, they're going to affect the rates of infection, the rates of hospitalization, the rates of death. And again, these will have a large, socioeconomic status will have a large bearing on those outcomes, because some people are just not going to have the ability to work from home, the ability to take off work. There's a lot in the way of people who are suffering economic disadvantage. It really does matter. So the authors have this table. This is table 4 from their analysis. And they decide up to July 30th, and then after July 30th is a good date because the program had already started. And they say, well, look, if we look at just up to July 30th, the hospitalization rate is high and the mortality rate is high. And then if we look at the period after July 30th through the end of the program, the hospitalization rate drops and the overall mortality rate drops. This is all in the city of Itajai. But plenty of other cities in Brazil, in fact, most of them, didn't have any such program like Itajai. And if we look at the exact same numbers to the extent that we can, Brazil-wide, we don't have access to the hospitalization numbers Brazil-wide, but we do have access to cases and deaths. And if I draw that line prior to July 31st or on or after July 31st, what we see is that several things. One is that there is also a much lower risk ratio after July 31st. And that's because the COVID situation across Brazil improved. For some reason, when they did this, which they wanted to say is related to the program being initiated and Itajai being saved by ivermectin, it also turns out to be roughly the peak of the first wave of COVID in Brazil, Brazil-wide, and so the rates began dropping after that. Now, the next question is, did the ivermectin user group, did the people in the ivermectin user group actually take ivermectin? And the answer is probably not. And this really undermines the whole thing. They probably didn't really take it. Now, why can I be so confident in that? Well, because the city of Itajai told us. The city of Itajai posted this. This was originally in Portuguese, but I translated it with Google Translate, and then Sean Purdy at University of Sao Paulo in Brazil confirmed the translation here that the city of Itajai this was just when they were starting vaccination. And so they posted this announcement on clarification of prophylactic treatments, and they're referring specifically to ivermectin. I'll start with the first paragraph. The municipal health department of Itajai, while celebrating the historic milestone of the start of vaccination against COVID-19 in the municipality and working to serve the entire population as doses are made available, regrets the content of some recent journalistic publications regarding the use of prophylactic drugs as a strategy to face the coronavirus pandemic. And then down at the bottom, they say, just as an example, when the health department started distributing ivermectin, 138,216 residents took the first dose. 15 days later, that number dropped to 93,970. Subsequently, only 8,312 people withdrew the third and fourth doses. That is, there was no biweekly continuity on the use of ivermectin as recommended. Now, this is the whole program. The whole point of this study is to claim that ivermectin use is associated with these better outcomes and less infections. But the city of Itajai is telling us itself that less than a tenth of the people who signed up for the program and therefore were included in the ivermectin user group were in fact regular ivermectin users. Less than a tenth came back and continued to pick up ivermectin. This undermines the inference of the study as being related to ivermectin use quite considerably. Now here, I want to take a little bit of a detour and talk about statistical lies, because there are some statistical lies lying straight ahead of us. The authors of this study have anticipated the argument that I just made, and many other people have noticed as a weakness in the study. And what they've done is they've done a new analysis that they've released is a preprint, and in that they say strictly regular use of ivermectin as prophylaxis leads to a 90% reduction in COVID-19 mortality rate, so even better in a dose-response manner. Definitive results of a prospective observational study of a strictly controlled population from a citywide program in southern Brazil. This is a preprint, and wow, boy, it sounds like they're really onto something here, right? Notice, though, remember from the abstract of this paper, in cases where a participating citizen of Itajai became ill with COVID-19, they were recommended not to use ivermectin. So, if they contracted disease, they stopped taking ivermectin. Why is that relevant here? Because the definition is what they call strictly regular users. So no longer regular users, as in the paper we've been looking at, but strictly regular users in this preprint. Now, how do they define a strictly regular user? This was pointed out to me by Dr. Kyle Sheldrick. This is from the Methods and Materials. Following definitions of regularity, we considered as strictly regular subjects those that used at least 180 milligrams, or 30 tablets, and as sporadic users, subjects that use 60 milligrams or less during this 5-month period. Comparison between subjects that did not use ivermectin and these two levels of regularity of ivermectin were performed. Analysis of the intermediate levels of ivermectin use are present, so on. Okay. So that sounds like maybe, I don't know if that sounds convincing to you. It might, because it looks like they're addressing the question that I raised earlier. But let's take a look at it. Here is a kind of schematic of some people getting sick. They enroll in this study, and some of them get sick, all of them except for the last year. The last year represents people who stay well. But for the other people, if they don't stay well, if they get sick, they're going to get sick at some point in time. So this represents from July, the beginning of the study, to December, the end of the study. And some of those people will get sick, and they'll get sick at different times. At this point, they'll stop taking ivermectin. How much ivermectin have they taken? In almost all cases, less than 180 milligrams. This means that only these last two, which includes everybody who didn't get sick, and the few who may have gotten sick at the very, very end of this study, are in the strictly regular ivermectin use group. And why do I say this 180 milligrams is that? Well, the average weight of an adult male in Brazil is about 70 kilograms, and that would require 30 pills. That person would be taking 4 pills every 2 weeks, and so that person would require 7.5 periods. So 7 or 8 periods to do that, to get like 30 pills. So maybe 8 periods. 8 periods of 15 days is 4 months. The study ran only for about 4.5 months. So it is basically near the end of the study that average 70 kilogram adult male would reach 180 milligrams. That means that everybody who got sick in the ivermectin group prior to that was dropped from the ivermectin group. They got tossed out. Nobody from the non-ivermectin group got tossed out. Every sick person from the non-ivermectin group was kept. But everybody who got sick, unless they got sick at the very tail end of the study, in the ivermectin group was not a strictly regular ivermectin user. This is, frankly, amusing in its transparent misuse of analysis, because this is a way to game the system. This is basically gaming the outcome so that the strictly regular ivermectin users have an extremely low rate of sickness and death, because basically most of the people who got sick are not counted in that group. They're just not. They're counted in the less regular users, or they're counted in the non-ivermectin users. Well, with that interlude, let's move on to this propensity score matching. So that's an important part of the study, and you may not be familiar with it, but it's a widely used method in statistics of observational studies. The rationale is that the very best studies are randomized controlled trials. But in an observational study, in a retrospective observational study, we don't have any opportunity to randomize, right? So when we're comparing groups, like comparing groups of potential ivermectin users to potential non-ivermectin users, or at least those who didn't take up the prescription, they may have lots of differences between them. Now, in propensity score matching, what you do is you create a subset of the groups so that you have equal size groups, and that the subset of the groups matches according to the covariates reasonably well. And there's a way to optimize that. There are a number of ways to approach this kind of problem, and it's a problem in multivariate statistics. This way of approaching it, what's called propensity score matching, which dates back to the early 1980s, has some advantage over alternative methods partly in terms of simplicity, because it uses this single score to match on these various different variables. So that's the basic idea of propensity score matching. It's widely used, but it is tricky. So this is a review article for clinicians that was published in 2019, and this is basically all about the details that if there are hidden variations, hidden covariates, or hidden differences between the groups, by definition, they can't be accounted for in the propensity score matching because there's no basis they're not included in the score. And so if they're omitted, it may appear that you're matching things, but it actually may exacerbate the non-matching, the areas in which they're different. Another paper, to use or not use, this was in Pharmaceutical Statistics last year in 2021. And this is a much more technical paper. The earlier paper was addressed to clinicians, but this points out some major problems, which is when you're using propensity score matching, even when the covariates are roughly balanced, the PSM might increase imbalance rather than reduce it, and the goal is to reduce the imbalance. And some critics have said you shouldn't use PSM. Others say that you can use PSM, but you need to watch out for biases. Now, in this case, and then they also say PSM was also criticized as there is no way to know in advance whether the method will work. Oh, okay, yeah, so then they go on. Indeed, PSM has two major potential flaws. First, in achieving a balanced propensity score, does not guarantee balanced prognostic factors between treatment groups. And second, pruning due to matching may be harmful if it is implemented inappropriately. The latter is a common issue to all matching methods, but is more problematic for PSM. And that is what I think happened here, because here the propensity score matching doesn't account for any variables that are related to risk. Just like, because they didn't even measure them or tabulate them, so no variable related to risk is there, and the propensity score matching is only matching those things that they did have: age, sex, and the comorbidities that they tracked. The self-selection is a wide open door for differences between the groups on socioeconomic status, but none of that is tracked. And so the propensity score matching may, in fact, exaggerate the differences between the groups rather than balancing them. Is this a real issue? Well, in the claimed results from propensity score matching, we see this very dramatic difference in deaths from COVID-19. They have 79 deaths in the non-ivermectin use and 25 deaths in the ivermectin use group, and this is of 30 3,034 subjects in each group with propensity score matching. This seems really dramatic, a really dramatic drop in mortality rate. But as first noticed by Jonathan Langston, Dr. Langston, on the Cureus website, it is also very suspicious that the propensity matching pruned 37 deaths from the ivermectin group in over 50-year-olds and not a single death from the non-ivermectin users. Generally, you match the controls to the intervention group. I find it highly unlikely that 37 of the deceased greater than 50-year-olds in the ivermectin group didn't have a match. So what is meant by that? What is Dr. Langston talking about? Well, in this case, here where I'm showing table 6 on the left from the paper, and table 6 on the left is is prior to the propensity score matching, the patients and their hospitalizations. And just focusing in on this part here, what we see is these are COVID deaths. This is overall COVID deaths. Here's in the ivermectin group, and here's in the non-ivermectin user group. 62 in the ivermectin user group and 79 in the non-ivermectin user group. But if we look after propensity matching, we can see that the non-ivermectin user group still has 79, but the ivermectin user group has dropped from 62 to 25 by dropping 37 people who died in the over 50 category. And this seems remarkable and unexpected. Now, I can't reproduce their data for the propensity matching. And the reason I can't reproduce their data for the propensity matching is because they don't provide enough data to make that possible. And they also don't describe a good description of their propensity matching, their propensity score matching, so that it could be reproduced. Even if I had the data, I'd be kind of guessing at a lot of it. Anyway, it doesn't. This is really problematic. They don't have an explanation for it. No author has addressed the questions, and that's I think indicative of the level of strangeness of the analysis in this paper. Now let me make some closing comments here. I realize this has taken a little while to do this. The paper itself is not all that complicated. It's relatively straightforward. There was a program in Itajai. They went and got some data. They analyzed the data. They published the results. This seems relatively straightforward. But in fact, it's very, very messy. And a lot of the way in which they did the analysis doesn't seem to have addressed those messes, and then they're making these strong claims. And so it winds up being kind of a hard video to make because it's a hard paper to explain, not because the underlying work is very difficult, but because there are a lot of weird alleyways that one has to go down in discussing this paper. Now, science is hard, and that's one of the things that I really like about it. That's one of the things that makes it enjoyable and engaging and fun. It's hard. It's the answers aren't easy. The answers aren't straightforward. I know on social media, people want kind of a hot take on the latest, on whatever the latest COVID situation is or other kinds of science. And that kind of battle, that kind of pugilism is not something that interests me particularly. I am interested in misinformation, and I want to respond to misinformation, and I want to address scientific developments that come up and that overlap with areas of my expertise and interest, but also those areas that overlap with misinformation. But I don't want to be somebody who's giving kind of the hot take on the most recent paper. And so this kind of slow burn that I like to do is probably going to be continuing because I think it's more edifying and more beneficial. And then I can always put in a little bit of educational content about things that hopefully help people not fall victim to misinformation, or maybe get a little bit of a scientific education along the way. Anyway, that's it for this. If you've enjoyed this content, feel free to give it a like. Let me know in the comments what sort of things you'd like to see in future videos. If you have questions, you can also let me know there. And in the meantime, I'll be doing some other content, but in the meantime, stay safe.